You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 26, 2023. This week, notes from the Heart Rhythm Society meeting, Impella failure, Sacubitril Valsartan, the purpose of clinical trials, and this is big, a major breakthrough in evidence generation. Now, before I say anything about the Heart Rhythm Society meeting, I want to say thank you to the many listeners who came up to me to say that you listened to This Week in Cardiology. This is no small thing. It means a lot to me. Really it does. Thank you times 1,000 for stopping to say hello. Last week, I closed the podcast by saying I'd have some new studies to talk about from HRS. Well, the news from HRS is a bit surprising. I don't have any major studies to tell you about. The late-breaking clinical trial sessions were notable for A, unfinished studies, B, non-random observational studies, which are surely confounded, and C, very small RCTs looking at surrogate endpoints. It was kind of shocking how little there is to report from the EP world. I mean, the areas of excitement at HRS, the sessions with standing room only, included cardioneural ablation to cure severe bradycardia, pulsed field ablation, a new way to destroy myocardium, and conduction system pacing. So, cardioneural ablation reminds me of pacing for vasovagal syncope before the sham-controlled trials. The idea is so enticing. Mostly young people with profound bradycardia, these patients who have long pauses due to vagally mediated sinus arrest or AV block, can be taken to the EP lab where a doctor burns the areas of the GPs, ganglionic plexi, which mostly reside adjacent to the pulmonary vein ostia. So in New Orleans, we saw beautiful case reports. The proponents of this are enthusiastic, their pictures lovely, their stories compelling. But I have to say that this is a scary trail we're about to ride our bikes on. It looks fine now, like all mountain bike trails do, but there are going to be rocks, roots, drop-offs, and danger coming forward. Cardioneural ablation needs only one thing, and that is a sham-controlled trial. Without that, we should be very cautious, resist the urge to take 20-year-olds with vasovagal syncope for left atrial ablation. Now, PFA, pulse field ablation, also generated great excitement. And if you thought left atrial appendage occlusion marketing is strong, wait till you see what happens when PFA passes FDA muster. Multiple companies are racing forward to provide this PFA for the lucrative AFib ablation market. Again, the proponents will tell you that PFA deliveries, each one is actually a shock that'll isolate PVs and isolate the posterior wall of the left atrium faster and safer. Safer because PFA is supposed to electroporate, that is, kill cells by causing pores in cell membranes of only myocytes, not the esophagus or phrenic nerve. A large PFA series presented at HRS, however, included a handful of phrenic nerve injuries, as well as strokes and tamponades, just like RF ablation and cryoballoon ablation. Now, as a doctor working in the lab each week, I am open to better, safer ways to do AF ablation. But as a chronicler of science, I put on my science hat, PFA does nothing to advance the knowledge of AF. I mean, the reason AF ablation has such dubious success rates is that we don't understand the causes of AFib. Of course, the other area of excitement, the rooms were packed, was conduction system pacing. And conduction system pacing was the topic of many LBCT presentations, only most of these were not trials, rather non-random comparisons. Conduction system pacing challenges my brain, right? On the one hand, it produces truly gorgeous paced ECGs, and the beauty of the ECG is what attracted me to cardiology in the first place. These narrow paced QRSs create synchronous RV to LV contraction, and by doing so, they avoid pacing-induced cardiomyopathy as well as simulate CRT therapy. Now, I went to a debate on left bundle branch pacing versus CRT. The young doctor was arguing for left bundle branch pacing, showed beautiful pictures, but the old doctor showed the oodles of RCTs supporting CRT and BiV pacing, and that's the problem. Traditional BiV pacing in CRT has been proven in many trials, outcomes trials. The tension in my clinical brain is that I love left bundle area pacing for its beauty and elegance and potential. But the medical conservative part of my brain, fed by the history of medicine and many of our failures, worries that we have no trials. Now, fortunately, there will be trials starting soon, and in years we will know, and I'm pleased to participate in one of them. Okay, one small note on a study from HRS that traverses both interventional cardiology and EP, and this has the theme, more is not necessarily better when it comes to LV assist devices. So Jack has published from Cleveland Clinic authors a first in-human experience with the Impella 5 series devices, and this is for support during complex VT ablation in patients with heart failure. Impella 5.0/5.5 is notable for even greater cardiac output, around, guess, 5 liters of cardiac output. This paper described Impella use in 41 patients. Now, the device is big and it requires surgical implant in the axillary artery. The authors compared the 41 patients from this study from a database that they propensity matched on lots of variables, so it's a non-random comparison. And they found success rates measured by death, LVAD, or transplant were not different in the two non-random groups. Neither was freedom from VT, which was below 50% in both groups, and I'll speak more about it at the end. However, and this is the big however with this study, complication rates were much higher in the Impella arm, 29% versus 2.4%. The higher rate was driven by surgery-related complications like access site hematomas, infected DVTs, PEA arrest during Impella placement, episodes of unstable VT requiring CPR, and 3 post-procedure tamponades requiring drainage. 3 of the complications in the Impella arm resulted in death. Now, the authors reported no decrease in complication rates over time, so they wrote that this is no evidence of a learning curve. Now, my comments. While this is a small series with a non-random control arm, it tells us a lot, right? A larger LV assist device, one with greater cardiac output, is unlikely to help patients referred for ablation in the end stages of their disease. Now, these are some of the best VT ablators in the world. Not only was there low efficacy, but there was also a clear signal of major problems with complications, and the Impella likely made it worse. Now, I'm not covering this small series because it shows a failure of an LV assist device. Rather, the larger issue here is one of the core problems of EP. That is, should we intervene? And when I started EP, the problem was having enough tools to help people. I think the problem now is much less about tools, but rather whether we should intervene. Refractory VT in the setting of heart failure is often a terminal event. Perhaps a small number of these patients can garner meaningful survival from a VT ablation, but many of these patients might be better served by a change in goals of care, and that is from life-prolonging care to care that is designed to relieve symptoms and enhance comfort. The graph in their paper shows that 70% of patients have recurrent VT by 12 to 18 months. Pause there. In one of the best centers of the world, 70% of both groups had recurrent VT by 1 year. To my EP colleagues, I would just say, don't forget that palliative care is often a great option. Okay, next topic. The heart failure experts also got together in Prague this week. One of the key studies coming from that was a trial called PARAGLIDE. This is a very interesting story, one that goes beyond a single RCT. Stay tuned for the added twist, and it's not such a nice one. Now, the Novartis-sponsored PARAGLIDE trial paired Sacubitril Valsartan versus Valsartan alone in patients with a worsening heart failure event who have an LVEF greater than 40%. So they enrolled early, within 30 days of the worsening heart failure event. Now, before I tell you more about PARAGLIDE, we should briefly go over PARAGON-HF, which was published in New England in 2019. PARAGON was a biggie, right? 5,000 patients with heart failure, LVEF greater than 45%. And it compared Sacubitril Valsartan to Valsartan alone, and here the primary endpoint was CV death or total heart failure hospitalizations. I recall that the primary endpoint was non-significant, hazard ratio 0.87, 13% reduction, and the confidence intervals range from 0.75 to 1.01. The p-value was 0.06, and there were no substantial differences in CV death. It was all driven by heart failure events. Later, after the trial at FDA, the sponsors promoted two subgroups that may have benefited more, women and those with EFs at the low end of normal. Anyways, PARAGON has 4,800 patients. PARAGLIDE enrolled 466 patients. The primary endpoint of PARAGLIDE cannot be clinical, therefore. Instead, PARAGLIDE looked at a change in NT-proBNP from baseline through weeks 4 and 8. Secondary endpoint they used was a win ratio and a hierarchical outcomes of CV death, heart failure hospitalizations, urgent heart failure visits, and a change in BNP. Now, the time average reduction in BNP was greater in the Sacubitril Valsartan arm, and it was a 15% reduction with a p-value of, get this, 0.049. The hierarchical outcome favored Sacubitril Valsartan but was not significant. Of course, there's just not enough events. It's a small trial. But Sacubitril Valsartan increased symptomatic hypotension by a lot, a 73% increase. The authors concluded, get this, quote, among patients with EF greater than 40% stabilized after a worsening heart failure event, Sacubitril Valsartan led to a greater reduction in NT-proBNP and was associated with clinical benefit compared with Valsartan alone, despite more symptomatic hypotension. Now, come on. This is not good. I don't even know what to say about this. I'm just going to stay calm. You enroll 10 times less than PARAGON. You barely, and I mean barely, meet the near meaningless endpoint of BNP. And what the heck is the clinical significance of a 15% reduction in BNP anyways? Then you find no differences in clinical outcomes and have 73% more hypertension in 71-year-old patients. How can you conclude that there's clinical benefit? Now, the more important question to me is, why was this trial done, other than marketing for Novartis? Why enroll 10x fewer patients than PARAGON and measure a near meaningless endpoint? Well, none other than super sleuth Romanian electrophysiologist Bogdan Inaki provides the answer, on Twitter no less. So Bogdan responded to my tweet and he said, what I was missing about this trial was that the purpose of it was a seeding trial. He pointed me and thousands of his followers to the simultaneous analysis with PARAGON published in a higher impact fact journal. Now, what does Bogdan mean here? Well, it turns out that the European Heart Journal published a pooled analysis of PARAGLIDE and PARAGON, this one looking at outcomes, CV death and heart failure hospitalizations. The authors of this pooled analysis start out by saying that PARAGLIDE did not have enough patients to examine clinical outcomes. Of course, that did not stop them from making that conclusion in check that I just told you about. Then the authors of the pooled analysis say that PARAGON, the heart failure trial that barely missed significance, had a subset of PARAGLIDE-like patients. Now, the way it's written, it seems like a big surprise, like they just thought of this, except the pooled analysis comes out the same day as PARAGLIDE. Now, recall that PARAGON was a multi-year trial. PARAGLIDE is a short, in months trial. So they took PARAGLIDE-like patients and combined them with patients in PARAGON for this pooled analysis. And here are the numbers of the pooled analysis. You go to Table 3 of the European Heart Journal publication. Now slow down here if you're running or cycling. In the big PARAGON trial, Sacubitril Valsartan versus Valsartan, the hazard ratio 0.87, 13% reduction, confidence intervals 0.75 to 1.01, p-value 0.06. Now, when you add in the PARAGLIDE trial to the pooled analysis, the hazard ratio is still 0.87, but the confidence intervals are now 0.76 to 0.99, p-value 0.04. You see what happens by adding the patients from PARAGLIDE, you get no difference in the point estimate, still a 13% reduction, but the added patients tightens up the confidence intervals. That's what Bogdan means, right? PARAGLIDE seeded the PARAGON trial. Of course, it serves no purpose to randomize 10x fewer patients in a trial measuring BNP, except for you get to add a few more patients to the PARAGON trial in a pooled analysis, which now reaches significance not because of a greater effect, but because of a slightly tighter confidence interval. But these are different trials, different patients, different follow-up, different circumstances, like 2 to 3 years later. Go to Table 3 again. In more than 5,000 combined patients in this pooled analysis who had heart failure, age 71, there were 16 fewer cardiovascular deaths in the sacubitril valsartan arm. That's an utterly non-significant difference. Yet also in Table 3, there were 170 more episodes of symptomatic low blood pressure, and that's a highly significant 50% greater rate. So my comments. I've been doing this critical appraisal thing for many years. This is the first time I have recognized this. What should I call it? Behavior. Proponents will say it's all good because the pooled analysis was pre-specified, but I'm not sure. Worse, Novartis actually harnessed a network of cardiology fellows recruited via this popular podcast called Cardio Nerds. That helped recruit patients at major centers. Indeed, involving impressionable young doctors in this process is money well spent by Novartis. The net benefit versus harm of sacubitril valsartan in HFpEF remains as dubious as ever. The net benefit versus harm of sacubitril valsartan in all forms of heart failure is also dubious. I mean, go back to Paradigm Heart Failure, had many problems, right? Namely the enalapril comparator, unequal run-in periods. Then consider the other trials. If sacubitril valsartan is as good as it's supposed to be from Paradigm, you'd expect it to crush it in other trials. But Paradise MI, post-MI LV dysfunction, sacubitril valsartan versus valsartan was non-significant. Life trial, same thing, class 4 heart failure, no difference versus valsartan. PARAGON-HF, we've already talked about, non-significant in HFpEF. And any trend of benefit in PARAGON-HF is not driven by CV death. The only positive trials with sacubitril valsartan other than Paradigm are near worthless BNP trials. I think the main lesson from this saga is that FDA and all in the heart failure community should have required 2 regulatory trials, not just Paradigm, but another big heart failure with reduced EF trial of sacubitril valsartan against equal dose valsartan. Okay, final topic, and this is a biggie. Final topic, a major revelation in medical evidence reporting, the Elan trial. New England Journal of Medicine has published a seemingly straightforward RCT comparing early versus late oral anticoagulation for patients who have had stroke from atrial fibrillation. But absolutely everything about how this trial was analyzed and reported is completely new. I love it. Now, ARNI team is frequently involved in post-stroke care of patients with AF, and the question of when to begin oral anticoagulation always comes up. We usually defer to neurology, so this topic happens to be also topically relevant to cardiology. Now, with the trial, Elan trial, about 2,000 patients with stroke due to AFib were randomized in 103 sites in 15 countries. The main question was early versus later initiation of oral anticoagulation, and the primary outcome was a composite, right? A good composite. Recurrent ischemic stroke, systemic embolism, major bleeding, symptomatic ICH, vascular death within 30 days, within a month. Now, secondary outcomes included components of the primary, but out to 90 days. Now, early and later were slightly different depending on the stroke severity, but it was still early versus late oral anticoagulation. These were 77-year-old patients, 45% female, CHA2DS2-VASc score 5, and about 60% of the strokes were treated with either lytics or thrombectomy. Here's the results. Primary outcome occurred in 2.9% in the early treatment group and 4.1% in the later treatment group. The authors expressed this as both a risk difference, absolute risk reduction, and odds ratio, relative risk reduction. The absolute risk reduction was 1.2% percentage points. 95% confidence intervals went from as low as 2.8% lower to 0.5% higher. Now, this is at 30 days. The odds ratio, or relative risk reduction, was 0.70, so a 30% reduction, and the confidence intervals went as low as 0.44 and as high as 1.14. Notably absent in this paper were p-values, and I will get to that. Now, looking at the components of the composite primary, most of the benefit came from 11 fewer ischemic strokes in the first 30 days in the early group. Major bleeding in the first 30 days did not differ much at all. The authors then did something interesting. They reported the composite primary outcome of stroke, systemic embolism, bleeding, ICH, and vascular death at 90 days. Recall the first primary endpoint was 30 days. Now here, at 90 days, they found 3.7% in the early group, 5.6% later, and an odds ratio of 0.65, which is a little bit less than the 0.70 at 30 days. But since there were more events accruing in 90 days, the confidence intervals were now 0.42 to 0.99, which is all on the positive side of the null. The next sentence, they say this was not a pre-specified endpoint. I don't know why not, because it seems like something we would really care a lot about. Okay, now the novel part. Here are the first sentences of their discussion. Quote, "This trial was designed to estimate the treatment effects of early initiation and later initiation of DOACs and the degree of precision of this estimate, period. No statistical hypothesis was tested for superiority or non-inferiority, and the results are intended to provide qualitative data that may be of use to clinicians, period." Here is the conclusion in the abstract of the New England Journal of Medicine. In this trial, the incidence of recurrent stroke, systemic embolism, major extracranial bleeding, symptomatic ICH, or vascular death at 30 days was estimated to range from 2.8 percentage points lower to 0.5 percentage points higher, based on a 95% confidence intervals with early rather than later use of DOACs. That's amazing. In the rationale paper, which is in the European Stroke Journal, and I'll link to it, the authors offer two reasons for not testing a specific hypothesis, such as non-inferiority or superiority. First, they say, when we designed a trial, there was a lack of high-quality data on event rates in this setting, making it difficult to identify an appropriate non-inferiority margin. Amen to that. Second, they write, the assumed low event rate would require a very large trial to assess either superiority or non-inferiority, and this would not necessarily provide greater clarity concerning patient management. And they then go on to say, although we propose a different analytic approach to that often seen in clinical trials, this should not hinder interpretation of the trial data or their clinical utility. And this is the absolute money statement. Sit down for this, stop your bike, stop running. They say, quote, "We also believe that the complexity of managing patients with AF early after stroke precludes simplified dichotomous decision-making, and it necessitates some leeway for individual decision-making." My friends, I don't know if you realize how revolutionary that statement is and this approach is. It excites me so much that I'm pretty sure I'm going to miss something important in this discussion. Let's start with that last sentence where they write, that the complexity of managing patients with AFib after stroke precludes simple dichotomous decision-making and, for the win, they write, necessitates some leeway for individual decision-making. This is the best thing I've read in a medical journal in like 10 years. I want to make a poster of it. I want to tell the heart failure community about this. Of course, trial results almost never allow for simple dichotomous decision-making. I mean, the key modifier in that sentence is simple, right? Because as a doctor, we always make dichotomous treatment recommendations. We either recommend treatment A or treatment B or treatment yes or treatment no. But it's never simple, and rare is the trial that makes this simple. For if it were simple, we would not need a trial, right? Say antibiotics for bacterial infection or pacing for heart block and insulin for type 1 diabetes. These authors are asking us to be mature, rational, probabilistic decision makers. They've randomized 2,000 patients to 2 strategies. They have provided the results with confidence intervals and not proclaimed one strategy won or didn't win. They make us use probability. It's beautiful. For instance, for the primary outcome, early anticoagulation looked better. The point estimate was 30% lower with early anticoagulation. Now, it could have been 56% better based on the lower bound or 14% worse based on the upper bound. They then make users of the evidence look at the components of the endpoints. Here, ischemic strokes look better, bleeding not much different. That's good to know. Then they do something even wilder. They present a data point that was not pre-specified but seems hugely relevant. They tell us the composite endpoint not at 30 days, which was the primary endpoint, but at 90 days. Here it's also better for early anticoagulation. The odds ratio is 0.65, a 35% reduction. But since there are more events, the precision is higher and the confidence interval is a little tighter. Now the confidence intervals are 0.42 to 0.99. And if that were a traditional analysis, if they had picked that for their primary endpoint, this would have been considered a statistically significant result. But alas, it was not pre-specified. Now, Sanjay Kaul from Cedars-Sinai has taught me to become a Bayesian person. He's let me use his Bayesian spreadsheet, which we're allowed to use here, encouraged to use here, because the authors don't stipulate a statistical hypothesis. By looking at it this way is not a do-it-yourself statistical plan. And here is what you come up with when inputting the event rates and using a totally non-informative prior. You find that there is a 92% chance that early anticoagulation is the better strategy. It's an 8% chance that it's the worst strategy. Now, the authors gave us an example of how to do this. They did this in the supplement. They used this sort of analysis to provide the probability that early treatment increased the risk of a primary outcome event by the upper bound amount of 0.5%. And they find there was a 98% chance that the early treatment did not worsen the risk by that much. That is exactly what I came up with when I put that data in using the upper bound. My comments is that this is totally amazing. I absolutely love it. The standard frequentist approach of interpreting a trial means comparing the surprise value of the data from a trial, assuming no difference, the null hypothesis. If it is surprising enough, p less than 0.05, then we say the treatment is effective. If it is not surprising enough, p greater than 0.05, we say a treatment doesn't work. And that always seemed crazy to me. And non-inferiority, right, is even worse, because here you have the still similar dichotomous choices, but added to that is the almost arbitrary, often too generous non-inferiority margin. I mean, left atrial appendage occlusion makes non-inferiority against warfarin in one component of the primary endpoint of PREVAIL, but the non-inferiority margin is 1.75 or 75% worse. Now, that margin is agreed upon before, but it's an utterly human decision. The Elan trial approach is elegant. You randomize, you conduct valid experiments. They had low dropout, reliable, and important endpoints. And then they let the users of the data make use of the data for the patient in front of them. Now we should do this for lytic therapy and stroke. Imagine that. Oh my. Here is another way that this approach provokes. It totally upends those silly colored boxes in guideline documents, doesn't it? And if that is true, if it upends that, then it upends quality measures, because colored boxes and quality measures belie the complexity of medicine. I mean, guidelines are fun. I love guidelines. Just summarize the evidence, but resist the urge to make all specific recommendations in color coding. Embrace the Elan way. Quote, we also believe that the complexity of managing patients with insert any disease you wish precludes simplified, dichotomous decision-making and necessitates some leeway for individual decision-making. Okay, I'm done. I hope statistical experts will weigh in. I can see issues here of not having enough power. I can see the issue of not doing trials willy-nilly. This trial was a bit underpowered, but not by much. I mean, look at that 90-day result. I'm so excited, and it was so much fun to do this podcast. I look forward to your feedback. I also am grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating. Even those 1 or 2 sentence reviews goes a long way to helping others find us. Till next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.